We talked about this slide yesterday, the day before yesterday, and there are certain terminology differences which might confuse you. So just to remind you, I tried to remind the stuff in the lab yesterday, but still I want to talk about something. Guys, listen to it very carefully. If you read here, for these demifacets, why we call it demifacets? They are not a complete facet, they are demi, they are like a facet. There are few who are complete facet, there are few who are demi-facet. And if we don't put the word demi-facet with them, it means we are talking something different. So correct your minds for this, number one. Number two, here you can see, for this inferior demifacet, what is written? Superior costal facet. And for this superior demifacet, what is written? Inferior costal facet. So the concept of facet is a different thing. And this thing, when we talk of costal facets, this is with reference to the rib. Because the rib who articulates, look at this rib. This is its superior facet, this is its inferior facet. So they put it this way, where the superior facet articulates, they call it superior costal facet. Superior costal, costa, where the superior part of the facet of the rib articulates. So don't mix these two terms. This is right, and what we know with the name of superior demifacet and inferior demifacet, that is also right. So correct yourself. And if just we write it articulates here, so with what? Nobody mentioned is a costal or is a demifacet. So be careful and watch out with these words. I hope this point is clear. Anybody who is still in doubt, I am ready to explain it again. Is all clear with you? So Faji, you just arrived and you start texting. Dad don't trust you? That you have reached to the school or... No.
So you're saying that there's a demifacet that articulates with another facet of the rib.
Look, what's your name? Yamin. Now if you have a pet name at home, any XYZ name, someone call you as Yamin, someone call you with that name, is there a difference? But anybody who's new to you, any new friend of you, he will be surprised, no, he's Yamin, he's not this name for him. Got it? So this demifacet, it has another name, and that is costal facet. So in this slide, the place where from where I have taken this thing, that is showing this word. Okay? Usually, commonly we use the term demifacet. We don't use this costal facet word a lot, but for your clarification, I remember some of the guys, they came to me, not guys, girls, what is this, why this orientation difference or what not, is this a mistake or what it is. Then I reconfirmed the whole thing, and then I wanted to clear it to you guys that we use demifacet or we use costal facet. If just word facet is used, don't take it. Don't get deceived with that. Be careful with these. Watch out for these words. Sometimes there's a trick in so many exam things. So you have to be very careful when you are focusing and targeting this stuff. And if the complete wording is not there, you better be careful. Otherwise, you'll cry off, I meant this. Nobody is listening your viewpoint at that time, because exam is blind. Whatever key says, that is the right answer. He never knows what you think. He knows what you have bubbled. That's it. So watch out this concept. So now going to our original discussion for today. Now, previously we were talking about the Thoracic Wall-1. And now we'll be talking about the thoracic wall-2. This is continuation. As I was trying to explain to you, these lectures are connected with each other. So now, going further, we know about these structures. It's just a revisit to reestablish our understanding. The bony landmarks, we know about who's this, we know about this notch, we know about its significance, we know this is the angle of Louis, sternal angle is also being used. So posteriorly, if we draw a line, we reach to T4 level. If we have a horizontal line going within the body from this place backwards towards the vertebral column, that will cut at T4 level posteriorly. And this is the xiphoid process. Costal margins. There we have the clavicle. Now, we cut the clavicle from the middle and it's going down. So, you came so late and you are leaving. Why then when you came? To your classes? So, this is one of the very important references, mid-clavicular line. So, this we use as a reference point. And if you recall, when we was about to enter for managing a patient who has tension pneumothorax, to relieve the tension part, Ayan, your class is there. So, this is our reference level, mid-clavicular line, and we can approach second or third intercostal space. These lines are very important, and you should be expected to be perfect with them. If you miss these lines, you'll be in trouble. So we have this mid-clavicular line or plane. Now next to it, just lateral to it, we had the presence of the nipple. And there is another line here, and that is where in the males, in the fourth intercostal space. And this is another line, this dotted line. What do you think this line is?
Memory line.
Mammary line. Good. So this is the line. So the ectopic, so it's not necessary that everywhere you find nipple in this place, it can be, it may be present in any other place also, but not commonly, rarely. So in those individuals, there is a pertinent mammary line, and that exists in men and women both. I had a picture, I wish I could have shown you. I saw that there's a lady, her breast is on the lateral aspect of upper thigh, and she's sitting on a chair or a stool, and the baby is just standing and having her feet. So that picture is there. It is in one of our famous book of surgery, Bailey in Love. It used to be there. Now they have removed that picture. But so this mammary line, it can traverse down. So this ectopic nipples, ectopic breast can be anywhere. Right? But let's not talk about it today. When we'll be talking about the breast next year, there we will talk about that. Nasu, you came late and now you're talking with Homer. No, then why are you looking at the side? So just focus here. But this mammary line, we are not using it here. I just mentioned for your understanding. We should not be mixing the mid-clavicular line with the mammary line. So accessory nipples can be located along this line. Now, we know that this is superior thoracic aperture. But clinician, they call it thoracic outlet. Please be clear with this word. This is thoracic outlet, and this one should be. So I'm not using thoracic outlet, I'm using superior thoracic aperture and opening in the thoracic cavity superior. It has no conflict with the thoracic outlet because it's not saying inlet, it's not saying outlet. It's just saying there is an opening, we can see superiorly, there's an opening, we can see superiorly. We are not saying people are entering from here or people are exiting from here. So please watch out for these terminologies. These terminologies, sometimes your concepts are fine, but once you play with the words, you got deceived. And then the answers where you can get the full marks, you lose your stuff. So please be careful while tackling such things. And these are important. Is that clear? Now going further, according to this must be inferior thoracic aperture. Now, let's make a section of not through the aperture, it's a section which cuts the whole torso transversely. We cut someone transversely. And now what we see, I'm not giving you any level. It's just randomly at any space. Okay? Any intercostal space, this section has been made. And you are looking at the vertebral body, transverse processes, the spine, the lamina, and then the canal containing spinal cord, and you are looking at the rib. And we were talking yesterday and we'll talk today how the ribs have been articulating with the demifacets and with the transverse processes. And anteriorly you are looking at the sternum, the body of the sternum, because this section is a horizontal section. And this orange line which surrounds all, this is the skin. Now, on this side, on the left side, I will bring the vascular things, and there I'll bring some other things. Here I have the neural and the muscular contacts. Right? So watch out carefully. So, intercostal muscles. What intercostal muscles which we have learned, let's put them all one by one. So now this is the external intercostal. You can see that it's coming all the way, but anteriorly it is deficient. It's not reaching to the sternum. It is being replaced by external intercostal membrane. So external intercostal muscle is anteriorly missing for a certain time closer to the lateral aspects of the sternum. Is that point clear?
Yes.
We are very fond of asking, if we put needle from here, from this space, from this part, how many layers of the body this needle will pierce? So then you have to be expected to be able to answer. If someone asks you, if we insert a needle just lateral to the sternal body, what layers it will be passing? So your answer should be skin, superficial fascia, deep fascia. External intercostal muscle should not be there. External intercostal membrane is the right word, which you should supplement. Be careful with this word. I'm trying to tell you time by time where are the places where you can be trapped and you can make mistakes. Even you know the stuff. Yes, Fadi.
Doctor, we said that the innermost is also deficient. Is it deficient near the
My
cell?
dear, did I reach to that place? Go with the pace. Right now I'm talking about external intercourse. When I'll talk about that, I have slides for that, 3, 4. I hope that will serve your purpose.
As we have external membrane, the external muscle, intercostal muscle, continuous with the external membrane.
Yes.
Why we only consider the innermost is not continuous?
My dear, did I talk about innermost?
Last time.
Forget it. Let's do it again today.
We make a cross-section what we're looking for inferior or
I don't care. You're looking from superior and inferior in this image. This is not an X-ray. It's the same. Okay? So that's why it's not mentioned we are looking superiorly, we are looking inferior. Is this clear so far to everybody? You know the direction of the fibers? External intercostal, they go like this. Now you are asking me question. Now we focus here. Nasu will tell you later, not now. So we call this muscle as, this is the external most layer. Now there is that membrane which I was talking about, and we call it external intercostal membrane. Now I hope everybody understand from where this membrane has been derived. After this, it's going reverse. Internal intercostal muscle. Now you can see there is something similar is being done here. It's not reaching completely there. So this is my internal intercostal muscle, and there is my internal intercostal membrane. So can you figure out the difference? Anteriorly, external intercostal is not complete. Posteriorly, internal intercostal is not complete. Clear? Going further, we call it internal intercostal membrane. Now, this is the innermost layer. It's never like this, because this is an incomplete layer. It is in patches. It is being, you will see it in certain places in the front, certain places at the side, and certain places at the back. Something wrong with this STC guys. They want to buy their stuff. I hate them for this. Huh? Who was asking me something?
Don't say turn off the light.
Huh? Turn off. Thank you.
Doctor, if you just press forget the network and you will stop.
Okay, if next time it comes, I'll listen to it. So now I hope it's clear so far. We have 3 layers, and we talk about 3 layers in abdomen also. There we change the name. Here we talk about the pattern of who's external, who's internal, and who's the innermost. We'll segregate. Sheikh, stop talking. We'll segregate. I can see things. You are drinking coffee, I have no problem. So now this is my innermost layer. Fine? And you can see it's not complete anteriorly, it's not complete posteriorly. So there is a guy which is anteriorly, and we name it different. We call it transversus thoracis, and then it's connected with dotted lines. That has some meaning. So transverse thoracis muscle, that is part of the innermost layer. Right? Now, there are certain other items also, but they are so tiny, so small, I'm not trying to show you here. So here is, in this cut section, you see the pleura, and there is the pleural cavity inside. 2 layers of the pleura, and then in between is the pleural cavity, pleural space, which contains the pleural fluid, and you can see the pericardial cavity also. The 2 layers of that also, and see how they looks connected, right? So now we can level it. We can call it costal pleura. We can call it mediastinal pleura. We can call it vertebral pleura. We can call it, if it was not a section, if it was reaching to the apex, we can call it apical pleura. When it is lining the diaphragm, we call it diaphragmatic pleura. So pleura, where it covers, we call it accordingly. When it is facing to the mediastinal surface, we call it mediastinal pleura. So this is not another pleura. This is the same thing, but when it reached to a different destiny, to make things more clearer, we give it a separate name. Make sense to everybody? Going further, there are the lungs within this pleural space, and now there is the heart, and there is the covering of the heart. So pericardial cavity, and obviously it should not be that big. There is heart inside also, and this is costo-mediastinal recess. Costo-mediastinal recess, we will talk about it next lecture. This is important concept. We talk about costo-diaphragmatic recess. Now this is costo-mediastinal recess. So there is a potential space inside directed towards the mediastinum.